Hello everyone, my name is Fumiaki Ishibashi. I belong to International University of Health and Welfare in Japan. I'd like to introduce our article titled Optimal Visual Gaze Pattern of Endoscopists for Improving Adenoma Detection During Colonoscopy. The adenoma detection rate ADR and number of adenomas per colonoscopy APC are quality indicators of colonoscopy. The monitoring and feedback of individual observation times are effective in improving ADR and APC. However, even if appropriate observation time is ensured, these quality indicators vary greatly between endoscopists. Other factors of inspection, such as the endoscopist's eye movement, can influence examination performance. Previous studies have shown that the visual gaze pattern (VGP) during the screening of the chronic lumen differs significantly among endoscopists. Analysis of VGPs demonstrated that endoscopists who tended to gaze at the periphery of the screen during the withdrawal phase had a higher ADR. However, the most appropriate VGP for improving ADR and APC is yet to be determined. In addition, it remains unclear whether modifying the endoscopist's VGP can be a straightforward method for improving polyp detection performance. So, to address this question, we built a computer program that could record the endoscopist's gaze point on an endoscopist video and integrate the coordinate information. So, based on this program, we developed a novel system by which endoscopists can determine their own VGP through audible alerts during colonoscopy and actively correct it in real time. We conducted the randomized control trial using this system, named Eye Tracking and Feedback System (ETF system). This is the video of the ETF system. The green circle is the visual gaze point in real time, so we can visualize this viewpoint. So 200 patients were randomly allocated to 4 groups, 3 intervention groups and 1 control group. 3 intervention groups were defined according to the range of the area of interest. This area of interest was set as the most peripheral area of the endoscopy screen, which was divided into 4x4, 5x5, and 6x6. For the intervention groups, endoscopist's visual gaze point was actively modified using the ETF system by hearing the audible alert. The modification was to see the peripheral area of the endoscopy screen. The primary endpoint of this study, APC, was significantly higher in the 6x6 division group than in the control group. The APC and the number of screen divisions were positively correlated. Importantly, the rate of gazing at the peripheral area of the screen was also significantly higher in the intervention group. So the strength of this study is that it is the first randomized control trial to verify the efficacy of modifying endoscopist's VGP during colonoscopy. Also, the detailed analysis of VGPs in 189 colonoscopies provided more reliable results than those previously reported. This randomized control trial shows the colorectal adenoma detection was improved by correcting the endoscopist's gaze to the periphery of the screen, especially by dividing the screen into 6x6 segments. In subgroup analysis, small adenomas sized 5 to 10 mm were significantly more frequently identified using the ETF system, whereas there was no difference in the detection rate of large adenomas larger than 10 mm between the groups. These results were similar to the region characteristics that the computer-aided detection (CAT-E) system could detect. Importantly, the detection rate of flat adenoma in the 6x6 group in our study was significantly higher than that in the control group, in contrast to the limitation of CAT-E in detecting flat lesions. This result indicates that our ETF system can overcome the limitation of CAD-E system. In conclusion, the newly developed ETF system successfully modified endoscopist VCP during colonoscopy. Adenoma detection improved using the ETF system as masculine divisions were used, with the 6 by 6 division being the best among the screen studied.